Hello, everyone. I hope that everyone is doing well. Thank you so much for joining us today. We'd like to go ahead and get started as you settle in. My name is Tali Carr. I am your host for today, and I am delighted to welcome you to the Council on Black Health's second national workshop. Now, typically, the Council on Black Health's workshops are held in person, and they're held over a 2.5-day period. Now, because of the ongoing pandemic, I'm sure you guys have heard a little something about that. We've decided to hold this year's workshop virtually. Now, we've been conducting business, all of us, in front of screens for more than a year now. It feels more like 5 years, right? And we recognize exactly how difficult it would be. It would be a pretty heavy ask if we were to ask you guys to commit to 2.5 days in front of your screen. So we're not going to do that. That's why we've chosen to divide this year's workshop into several sessions that will take place throughout the year. Now, the theme for this year's workshop is leading the charge for realizing healthy Black communities. Now, hopefully you were able to catch the first session. The first session was Reset Your Mindset, Decolonize Your Thinking. Now, if you missed that, feel free to become a member of the Council on Black Health by visiting our website, which is www.councilbh.org. Members can access all of the previous session content there, so make sure you visit our website. Today's event is the second in a 5-part series that will last throughout the year. Our theme for today is In This Moment. I'd like to welcome the Council on Black Health's board chair, Dr. Renee Branch Kennedy, to bring you greetings for today. Dr. Kennedy.
Thank you. And thank you, family. Good afternoon. We're so glad that you've joined us today. And it is my absolute honor to bring you greetings on behalf of the Council on Black Health's Board of Directors. When I think about why I joined the board, I'm reminded of the late John Lewis's quote, "If not us, then who? If not now, then when?" We are throwing down the gauntlet for reimagining Black health. And it's our hope that these workshops will provide fuel to you for doing just that, for joining us in this time of transformation. In a few minutes, you're going to hear from the Council's exemplary, outstanding executive director. We love her, Dr. Melissa Glover. She's going to talk about our action plan for the next few years. And we really want to sincerely invite you to provide input. Give us your thoughts on this action plan. And importantly, join us in achieving our vision of realizing healthy Black communities. It's going to take all of us working together, but working together, absolutely, we can achieve it. Thanks again for coming.
Okay, thank you again, Dr. Kennedy. We are ready to get started. I hope you guys are. We'd like for everyone who's in the audience to help us elevate today's conversation on social media. This is going to be a great time for you to put those Twitter fingers to work in a good way. Sometimes that can go left, but not today. So please feel free to tag the Council using the social media handles and hashtags that you see on the screen, and they are available in the chat as well. All right, next up, I have to echo the love. I think we all love her. I know I do. She's the Council's executive director, Dr. Melissa Witt Glover. Lots of love, lots of love. Dr. Glover, welcome.
Thank you so much, Tali, and thank you all for being here. This is fantastic. I'm absolutely thrilled to see so many folks turn out, and I just wanted to give you a little bit of information about where things are going with the council right now, just so you have a sense of where we are. So I'm going to give you a little state of the Council on Black Health. Before I begin, I want to just do a couple of recognitions. Number one, many of you know that we were formerly the African American Collaborative Obesity Research Network and became the Council on Black Health in 2018. I just want to always recognize that we are standing on the shoulders of giants. And so want to recognize our founding chair, Dr. Shariki Kumanyika, who founded ACORN. back in 2002, and you will hear from her later on and part of the panel, but always want to recognize her. And then unable to make it today, but certainly spearheading the efforts for leading this workshop, and you see her on many of our webinars, is our strategic advisor, Reverend Siobhan Arline Bradley. So in her absence, I want to just acknowledge her efforts. And we would be remiss if we did not remember a friend of the Council on Black Health, Dr. Jerome Williams, who passed away this year. But Jerome has been a part of the council from the very beginning, has always been an avid supporter, both financially and also as a part of being a part of the programming teams, and really just supporting our work. We will miss him terribly, but I would be remiss if I did not acknowledge Dr. Williams and the important role that he has played with our work. Last but not least, before I get going, I do want to just shout out our workshop planning committee, who did a fantastic job of putting this together. All of the great things that you see and hear today, please congratulate them. If anything goes wrong, it is my fault. So I acknowledge them, and special shout out to Adrian Cherry and Tiffany Eaton, who are in the background running things. And so if you have any questions or have any issues as we're going through, please feel free to reach out to them. So just want to give you a quick overview of the council for those who are not familiar with us. Our vision for the council is realizing healthy Black communities. Our mission is we are working toward developing and promoting solutions that achieve healthy Black communities. And we do that as it relates to individual behaviors, so nutrition, physical activity, weight, behavioral health, and clinical care. But we know that individuals are impacted by social and political determinants of health. And so we want to make sure that the work that we do is addressing those areas as well. And our work with individual behaviors and then social and political determinants of health that impact policy systems and environments should then impact chronic disease outcomes that are prevalent in Black communities. Now, we do our work through 4 pillars. You can get lots more information about this on our website. In the interest of time, I won't go through a lot of this, but I will say our 4 pillars are partnerships. So the organizations and the individuals that we work with. So as you are listening and thinking about the work that we're doing in the council and how your organizations can get involved, please know that partnerships is something that we are seeking to do. Realizing healthy Black communities is a lofty goal. We cannot do it alone, nor would we attempt to try. So we need all of you to help us with that. Problem solving is our research pillar. So what research do we need to look at to be able to improve healthy Black communities? And so problem solving research, which is the pillar that we're built on. We want our partnerships and our research or problem solving to then impact policies, because we know that we can make a difference, but we've got to have policies and accountability for those policies in order for that work to be realized. And so we work on policies as it relates to addressing health in Black communities. And then finally, permanence. And so we have a running joke in the Council on Black Health that when we all retire and move to Tahiti, we want to make sure that there's a group of folks that are coming along behind us that are doing this work. And so we want to make sure that we have folks that are coming along behind us. And so we work on training and building the pipeline of well-trained thought leaders who are committed to a Black health agenda. Now in 2020, we had our inaugural meeting of the Council on Black Health, and we had our new name. And the theme of the conference was translating evidence into action. And so we had several action items that we came up with there, and you can see what they were. So our 2020 action agenda. We know that we had a pandemic. Tali mentioned that we had a pandemic, but I'm excited to say that through the hardworking volunteers, board, and members of the Council on Black Health, we were able to achieve all of the things that we set forth to do in 2020. So continuing to develop the infrastructure of the council. I came on board as the executive director in July of 2020, and we have started moving forward with sustaining our infrastructure. Many of you have seen opportunities now where we have rolled out our plans for membership. You can now become a member of the Council on Black Health by visiting www.councilbh.org. We have moved forward with our project related to developing a national Black organization collaborative. And so the council is proud that we are in partnership currently with 5 national Black organizations. They are the 100 Black Men of America, the Black Women's Health Imperative, Delta Sigma Theta Sorority Incorporated, the NAACP, and the National Black Child Development Institute. And together we are working on opportunities to address policies that impact Black health. And we've got lots of work that's going on there. We are working on a targeted marketing project. Dr. Kumanika may mention this later, but working on a project looking at celebrities and marketing and healthy food products in our communities. We routinely are doing webinars. So you may have seen that we're doing lots of webinars related to improving health in Black communities. I'm going to skip to the last one. We are moving forward with developing an action agenda. And then most exciting that's happened in the last year is in April, we released the nation's first Black Health Bill of Rights, which was developed and adopted at our workshop in 2019. And so sorry, my screen's going crazy here. So the Black Health Bill of Rights, which you can find on our website, is our declaration from the council as our frame of reference for the actions that we're going to take as a part of the council toward bettering the health status of all people of African descent. And our work will advocate, educate, and promote solidarity and respect while underscoring the dignity that we all have as individuals and families in our communities. And so we know that this Black Health Bill of Rights is created for people of African descent in the United States, but we know that these statements can be applied to people of the African diaspora worldwide. And so we just want to acknowledge the folks that were a part of this, and then just share with you so you can all keep in mind what our values are, the articles within the Black Health Bill of Rights. And these are a critical framework for thriving and living a full life. And so you can see the articles here. So we believe in the Council on Black Health that we have a right to a culture of health that values our whole well-being and allows us to achieve optimal health. And optimal health is not just the absence of disease, but thriving and living. And so we believe that. We believe that we have a right to receive respectful and dignified health care, regardless of class, regardless of gender, regardless of socioeconomic status. And so we have a right to receive that. We have the right to engage in a healthcare industry and receive healthcare that is culturally sensitive and that also incorporates cultural humility and equity as it relates to structures in which we receive our care. We have the right to approach solutions to Black health from a strengths-based approach and an approach that incorporates a decolonized and intersectional lens to health equity. And if you were not here on July 28th, you missed a great session where Drs. Joya Creer-Perry and Reverend Starsky Wilson broke down what decolonization means and what it means for us to decolonize not only research and health, but also decolonize our own mindset so that we can begin to think about what we're doing in terms of health. Last three, we have the right to transform our health by reclaiming our power and autonomy. We have the right to honor and incorporate lessons from our past, present, and future as a pathway to restoring our health. And finally, we have the right to have our full humanity honored and valued. So these are the things that we believe as the Council on Black Health, and our action plans and the work that we are going to be doing moving forward will be based on achieving these rights. We invite you to join us on this journey by visiting our website and becoming a member. You can ask any questions by contacting us at info@councilbh.org. And we are excited to continue to present to you during this session. You'll hear more opportunities for you to get involved, and you'll also hear an exciting rollout of a plan for the work that we'll be doing moving forward from Dr. Kamara Jones. So again, I thank you from the bottom of my heart for being here and look forward to working with you all in the future. And I'll turn it back to you, Tali.
All right, thanks a lot. You see why we love her, Dr. Glover. Make sure you follow her on Twitter as well. If you go to the chat, her Twitter handle is in there. Definitely a great follow, great lady. All right, thank you for sharing that, the state of the council and the action plan moving forward. If you're interested in joining the movement, again, the council's website is councilbh.org to become a member. Please also keep the conversation going on social media, those social media handles and hashtags on your screen right there. Okay, our first keynote speaker is Dr. Kamara Jones. You can read Dr. Jones' full and very impressive bio. It's in your workshop materials if you want to check that out. Dr. Jones is the past president of the American Public Health Association, and she is currently the 2021-2022 University of California, San Francisco presidential chair. She is well known for her work in many areas, including her work in defining institutional racism, personally mediated racism, and internalized racism in the context of modern US race relations. Her allegories on race and racism have been important to the overall conversation in helping to illustrate a topic that has been difficult for many, not only to understand, but even to talk about and discuss. So feel free to drop your questions and your reactions during the keynote address in the Q&A box, okay? And we'll get to them as much as we are able to. All right, everybody, let's give a warm welcome now to Dr. Jones.
Thank you, Tali. And I am so delighted to be here. And thank you, Dr. Kumanyika, for your groundbreaking work on so many levels and as the founding director and spirit force behind the Council on Black Health. So I have to warn you that there's a thunderstorm moving through Atlanta, and my internet has been a little unstable so far, so I hope that everything goes well here. But I just wanted to share in a few minutes some ideas about sustaining a national campaign against racism. And I say sustaining because so many people have recognized that with COVID-19 and the murder of Mr. George Floyd and so many before him and so many after, that there are more and more people who are willing to say the word racism, put together the words structural racism or systemic racism. But we really need to make sure that this is not just a moment, but a movement. And when I was president of the American Public Health Association 5 years ago now, following directly after Dr. Shariki Kumanyika, who was the president before me, I launched our association on a national campaign against racism with 3 tasks. To name racism, because if you don't name a problem, you will never be able to start dismantling that problem or addressing it. But after naming racism, we must move to action, because even though naming racism is necessary, it is insufficient. So the second of the 3 tasks is to identify levers for intervention, targets for action, by asking the question, how is racism operating here and here and here and here? And taking this question with us everywhere. And then once we identify some levers for intervention, we need to organize and strategize to act, because collective action is power. Collective action will protect us and propel us and inspire us and inform us. I am proud to say that at least this campaign, which was for the American Public Health Association, and as many other organizations, communities as would join us, is indirectly related to the first of what are now 208 declarations and counting. Last time I looked, 208 declarations by city councils, county commissions, sometimes governors or state legislatures across the nation, declarations that racism is a public health crisis, which started in Wisconsin, Milwaukee, Wisconsin. And this is how ideas spread. So month by month, you can see states that had something like this. After April, you see the impact of COVID. After May, you see the impact of the murder of Mr. George Floyd. But month after month, we still have more and more states which have at least one city or county, or in, I think it's 11 instances at the state level, declarations that racism is a public health crisis. You can look here and see anything going on in your state. If so, you should probably hook up with the people who are doing those things. If not, maybe get something started. If you go to the web page for the American Public Health Association, you can not only see where the declarations are, but you can click through and see the content of those declarations, which is going to be my first point. Because it's all well and good for a city council or a county commission or even a governor or a state legislature to make a declaration that racism is a public health crisis. But then what? Naming racism, necessary but insufficient. We got to move to action. And even that first step of naming racism, there are 4 key messages that we need to convey when we name racism, because there's a lot of confusion out there and actually reticence, denial, in fact. So the first of these 4 key messages is that, yes, racism exists. The second key message is that racism is a system. The third is that racism saps the strength of the whole society. And the fourth is that we can act to dismantle racism. So I'm going to just quickly give you an allegory to help get across the first message that racism exists. This one of my teaching stories based on something that happened in my own real life. I call it Dual Reality, a restaurant saga. And my real life experience that prompted this story is that as a first-year medical student, one Saturday I had awakened early, started studying, because I was very diligent, very studious. It was midday, some friends came over, and did they distract me from my studies? Oh no. We all got to studying long and hard, and now it's getting late. And we're getting hungry. And I have no food in the apartment, which was so typical of me that my friends understood. They said, never mind, Kamara, but we are hungry. Let's go into town and find something to eat. So we do. So we go into town and we find a restaurant and we walk in and we sit down. And the menus are presented. And we order our food and the food is served. And here it is. Here we are eating. So not the story you thought I was going to tell you about racism in a restaurant, perhaps. But hold on, there's a story in here. As I sat there with my friends eating, I looked across the room and I noticed a sign that was a startling revelation to me about racism. So now maybe I've intrigued you and you're wondering, Dr. Jones, what did the sign say? Okay, what did the sign say? The sign said, open. So now maybe I've lost some of you. So let me recap. Here we are sitting up in a restaurant eating. I look across the room. I see a sign that says open. Thinking no more about it, I and any of us might assume that other people could walk in, sit down, order their food, and eat. But because I knew something about the two-sided nature of those signs, I recognized that indeed now the restaurant was closed due to the hour, but firmly closed, and that other hungry people just a few feet away from me, but on the other side of that sign, would not be able to come in, sit down, order their food, and eat. And that's when I understood that racism structures open, closed signs in our society. That racism structures, if you will, a dual reality. And for those who are sitting inside the restaurant at the table of opportunity eating, and they look up and they see a sign that says open, they don't even recognize that there's a two-sided sign going on because it is difficult for any of us to recognize a system of inequity that privileges us. So, for example, it is difficult for men to recognize male privilege and sexism. It is difficult for white Americans to recognize white privilege and racism. In fact, it's difficult for all Americans to recognize our American privilege in the global context, except we are living at large right now with how much of the global supply of COVID-19 vaccine we have sequestered in this country. Now, those on the outside are very well aware that there's a two-sided sign going on. First of all, because it proclaims closed to them, but they can look through the window and see people inside eating. So, back inside the restaurant, to those who ask, is there really a two-sided sign? Does racism really exist? I say, I know it's hard for you to know when you only see open. In fact, that's part of your privilege, not to have to know. But once you do know, you can choose to act. So it's not a scary thing to name racism. It's actually an empowering thing to name racism. It doesn't even compel you to act, but it does equip you to act so that if you care about those on the other side of the sign, which is an if, then you could even talk to the restaurant owner, you know, who is, after all, inside with you. You could say, restaurant owner, there are hungry people outside. Why don't you open the door, let them come in? You'll make more money. And oh, the conversations we could have. Or maybe what you'll do is pass some food through the window. Or maybe you'll try to tear down that sign or break through the door. But at least what you won't be doing is sitting up saying, Wonder why those people don't just come on in and sit down and eat. So whenever I have 5 or 6 minutes to share with an audience, now here I'm sharing it with us because this is a good communication tool for you all to remember and then share it with others, right? But whenever I have to communicate to a group of people, many of whom are in disbelief or in staunch denial that racism exists, that yes, racism does exist, this is the story I tell, because racism is structuring a two-sided or multi-sided sign in our society. It is structuring a dual or multifaceted reality. And I actually, when I was talking to a group of folks in Flint, Michigan, now it must have been about 5 years ago, I started a 3-hour conversation with this following question. How could people who were born inside the restaurant know something about the two-sided nature of that sign? And it was a 3-hour conversation because there are many, 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 many ways to know. I will say this, that I am heartened that more people who were born inside the restaurant do seem to have a sense that there's something going on with the sign. There is something beyond open going on there. There are more and more people who were born inside the restaurant who just a year and a half ago might have been sitting there eating saying, what are those people outside saying? Black Lives Matter? Don't they know all lives matter? Who now are affirming, yes, Black Lives Matter. As I said, there are more people saying the word racism, saying structural racism, systemic racism. I am heartened by this, but I give all of us a warning, all of us, that if we just say a thing, even if it's a declaration that racism is a public health crisis, as even the CDC has gone on record saying, if we just say a thing and post it on our company or organizational websites, or we tweet about it or whatever we're doing, 6 months from now, we are at risk of forgetting why we said that thing. Because racism denial is so staunchly held in this society, and it's so seductive that we are at risk of falling back into what I describe as the somnolence, the sleepiness of racism denial. So we have to go beyond naming racism to action. We have to pull down that sign. And of course, racism is not just a sign. It's the sign, it's the door, it's the lock. There is a whole system going on. So we need to dismantle the lock, take the door off the hinges, because once we start acting, we will not forget why we are acting. So I'm going to very quickly share with you my definition of racism. This story that I just told you and this definition are just quick tools, superficial but very quick tools for that first of the 3 tasks for a national campaign against racism. So when I say the word racism, I'm clear I'm talking about a system. So I'm not talking about an individual character flaw or a personal moral failing or even a psychiatric illness, as some people have suggested. And yes, racism can manifest in those ways. But in its essence, racism is a system of power. And a system of doing what? A system of doing 2 things, of structuring opportunity and assigning value. And on what basis is the opportunity structured, and on what basis is the value assigned? It's based on so-called race, which is the social interpretation of how one looks in our race-conscious society. What are the impacts of this system? Well, when we think about it at all, we understand that racism unfairly disadvantages some individuals and communities. But it shouldn't take us long to recognize that every unfair disadvantage has its reciprocal unfair advantage. So yes, racism is also unfairly advantaging other individuals and communities. That's the whole issue of unearned white privilege that we hardly ever talk about in this country because it makes some people, especially some people who are living as white, uncomfortable. I used to apologize when I would get to this part of my definition, and I would say, if you feel uncomfortable as a white person recognizing and acknowledging white skin privilege, I used to say, just shake it off, stay with me. I'm going to tell you some more stories. I do not apologize anymore. What I say now is, if understanding how racism is unfairly advantaging some individuals and communities makes you uncomfortable, you need to lean into that discomfort. Because I have come to recognize that for all of us, the edge of our comfort is our growing edge. But the third impact of racism many of us miss, and that is that racism is sapping the strength of the whole society through the waste of human resources. If I had another 8 minutes, 10 minutes, I would go deep on this, but I do not. I know I do not. I just want to say that that last point about how racism is sapping the strength of the whole society may be the most important point to lift up right now in these days through our media stories, through data collection, through conversations around our dinner tables, so that we engage more people with, and fill them with a sense of urgency to dismantle this system and put in its place a system in which all people can know and develop to their full potentials. So very quickly, and I'm looking at my time, I think I have about another 9 minutes. Is that right, Tali? I saw you came on. Okay, so I just want to make sure that I'm.
Oh, you're good. You're
I'm
good.
timely. Okay.
You're good.
Okay. So that first of the 3 tasks for a national campaign against racism is to name racism. The second is to answer this question: how is racism operating here? Which is a legitimate question, because racism is not a miasma or a cloud that we can't get a handle on. It is a system with identifiable and addressable mechanisms which are in our structures, policies, practices, norms, and values, which, as it turns out, are actually the elements of decision making. Structures are the who, what, when, and where of decision making, especially who's at the table and who's not, and what's on the agenda and what's not. And so next time you're setting a decision-making table or find yourself at one, your first job should be to look around and ask, well, who is not here, who has an interest in this proceeding? And then your job is not just to represent their interest. Maybe in the short term you have to do that, but really the job is to create space, to find them a way to the table. And if structures are the who, what, when, and where of decision-making, policies are the written how of decision-making, practices and norms are the unwritten how of decision-making, and values are the why. And if we take this question, how is racism operating here with us everywhere? How's racism operating here in my child's daycare, or in my workplace, or in my community or neighborhood, in my city, in this nation? We can identify, or with regard to police killings of unarmed Black and brown men and women, or with regard to whatever it is, with regard to the disproportionate impact of COVID-19 on communities of color. I have used this question to identify 5, 10, 15 initial possible targets for action, targets for intervention, anytime I'm going to do a talk. I knew I didn't have time to do that right now, but I recommend this question to all of us highly. So that was the second of the 3 tasks. The third of the three tasks is to organize and strategize to act. So I am just going to very quickly share with you an idea for an anti-racism collaborative with 8 collective action teams. And I would love it if the Council on Black Health would want to embrace some aspect of this framework as part of a 3-dimensional lattice. I'll explain more about that if we have time with questions. But in the meantime, let me, for each of these 8 collective action teams, share with you some guiding questions and early ideas for action. So on communication and dissemination, the guiding questions would be, how can we support the naming of racism in all public and private spaces? And what tools and strategies are needed to start community conversations on racism? Where early ideas for action include developing a communication toolbox, allegories, billboards, films, podcasts, songs, tweets, webinars, 1619 Project, right? And also putting racism and anti-racism on community agendas at workplaces, anti-racism chats, or civic dinners in cities, or town hall meetings in whatever format that you want. The second of the 8, Education and Development Collective Action Team. How can we support training around issues of race, racism, and anti-racism at educational institutions of all levels? What does effective anti-racism curriculum even look like? Where early ideas for action include convening anti-racism scholars and activists to develop curricula for schools of public health, medicine, social work, law, etc., as well as developing curricula for K-12 education. And also, I want to throw my little pitch in there. I hope to develop each of my allegories. I have 6 or 7 in the public domain, but 30 or 40 in my computer, as a series of children's books, so that teachers, librarians, parents who never were talked to about racism would have tools to talk to their children about racism. The third of the 8 collective action teams, Global Matters. How can we use the International Convention on the Elimination of All Forms of Racial Discrimination, ICERD, to support anti-racism work in the United States? Many of you have never heard of ICERD. Most people in this country have not, but it's an international anti-racism treaty that was adopted by the United Nations General Assembly in 1965. The US signed it in 66, ratified it 28 years later in 1994. We have obligations under this treaty to do right under this 9-page treaty. Also, what can we learn from anti-racism work in other nations? So early ideas for action include informing the US public about US obligations under ICERD, examining anti-racism efforts in other countries, including countries that might be doing truth and reconciliation approaches or other kind of structural approaches, and participating in global conversations, not just on racism, because people might be not talking about racism. They may be talking about imperialism or colonialism or any other number of things, but all of these systems of structured inequity have a common structure. I could say more about that for a lot, but I won't. The fourth of these 8 collective action teams on history, very important. What is the history of successful anti-racism struggle in the United States and around the world? How can this history guide our anti-racism work today? And how can we institutionalize attention to history in all decision-making processes? I would say, furthermore, how can we all learn our full histories? And the attack right now on teaching history at all levels of our educational system under this anti-critical race theory thing is a very deep attack. It's dangerous, it's fascist. So early ideas for action for a history collective action team would be to teach our full histories, to hire historians, to staff all of our decision-making bodies, city council, state legislatures, US Congress, because if you are trying to untie a knot, wouldn't you be better served to understand how that knot got tied? The liaison and partnership collective action team, what anti-racism work is happening at the community level? And what anti-racism work is happening in other sectors, and how can we create linkages? So early ideas for action include cataloging and connecting local anti-racism efforts throughout the nation and around the world, and drafting, and wouldn't the Council on Black Health, this would be an amazing thing to do, to draft an anti-racism commitment agreement for communities, businesses, and organizations across sectors. With regard to organizational excellence, how do we answer the question, how is racism operating here in each of our settings? How do we examine structures, policies, practices, norms, and values? And I've done some thinking, especially about values and policies. So with regard to policies, I've identified 4 classes of policies that are mechanisms of structural racism. Those policies that allow segregation of resources and risks, those policies that create inherited group disadvantage or its reciprocal inherited group advantage, policies that favor the differential valuation of human life by race, and policies that limit self-determination. But that same kind of analysis we could apply to looking at, how do we look at structures? What are we looking for? Who's at the table and who's not? Well, that for sure, but how do we go deeper? And with regard to the policy and legislation collective action team, what are current policy and legislative strategies to address and dismantle racism, and what new strategies should we propose? So early ideas for action include cataloging formal anti-racism policies adopted by US jurisdictions. Here, I could now put 208 jurisdictions across 37 states that have passed formal declarations that racism is a public health crisis. Let's examine the content of those. Are any of them reaching out to invest in communities or to go to community decision-making tables or invite community members to their decision-making tables? Are there policy checklists? What is going on there? We also need to develop and disseminate model legislation to address the mechanisms of structural racism. And finally, with regard to science and publications, what research has been done to examine the impacts of racism on the health and well-being of the nation and the world? Yes, we got a lot of that documenting it. But then what intervention strategies? Oh, Jesus, there's a huge, sorry, you probably can't even hear it, but big thunder. I hope that you guys are still seeing me, that my internet is all right. But anyway, sorry, I'm all right. What intervention strategies have been evaluated? Because we've been documenting the adverse impacts of racism on at least the health of people of color. We haven't really gone deep into the health of the nation, the whole, how it's sapping the strength of the whole society. But we have some penicillin for that. That's right. We can invest vigorously in our communities and the like. And then what new measures and methods are needed? So early ideas include putting measures of racism on population-based surveys, especially national ones, but furthermore, developing the science and practice of anti-racism. If we had really focused on anti-racism, we could have predicted that an Obama would be followed by a Trump. So what can we do today? Going back to that image of the dual reality, we need to actively look for evidence of two-sided signs. Is there something differential going on here by race, by gender, by language, by urban, rural, by religion, by anything, looking not just at outcomes, but also at opportunities and opportunity structures. We need to burst through our bubbles of experience to experience our common humanity on the other side of town. Whatever size your little bubble of experience is, and whether it's tinted, whether it's polarized, most of us do not know that just across town there are other people who are just as kind, funny, generous, hardworking, smart as we are, who are living in very different circumstances. We need to create at the individual and institutional levels bubble bursting opportunities so we can experience our common humanity on the other side of town and thereby, and in different circumstances, and grow common cause. We need to be interested in the stories of others, believe the stories of others, and join in the stories of others. I'm heartened that over this past year and a half, more people have been doing that. We need to develop a sensitivity to the absence of who's not at the table, what's not on the agenda, what policies are not in place that if put in place could be more about justice. We need to reveal inaction, lack of action in the face of need, because that is how structural racism most often shows up these days. But all the power is not just on the part of those inside the restaurant. Those of us on the outside need to know our power, recognize that action is power, and especially that collective action is power. So thank you very much for this opportunity to infuse a few of my thoughts into this conversation. I am looking forward to participating and learning from the rest of the day.
All right, Dr. Jones, thank you so much. I think that was God saying amen to what you were saying, that thunder that we heard. We didn't have any specific questions in the comments, but there were a couple of people that from your past that were glad to see you again. So you may want to scroll back and see some of those names you might recognize and how you are still pouring in and impacting their life. But Dr. Jones, thank you again. That was very, very, very good.
Thank you so much.
Okay, next we're going to hear from a panel of experts, more experts on the way. It's a session that we have titled, We Are No Longer Asking Permission to Save Our Own Lives, Bold Action for Change. Now, we want to give credit to Birth Detroit for introducing this mantra back in 2019. Now, the concept of taking charge of and leading efforts to improve our own health is directly in line with the work of the council, realizing healthy Black communities will take bold action. Again, all speaker bios from this panel, they are in your workshop materials. We won't go in depth here on camera, but you can go to your materials there and you can read up on those bios. Okay, let's welcome an award-winning, very talented journalist, very special person, Mr. Bruce Johnson, as the moderator for this session. Bruce, I'm going to turn it over to you, man. Welcome.
Thank you very much. Let's see. I'm told that the host. Let me see if I can start my video here. Boom! There I am. Thank you very much. Really appreciate it. This is incredibly exciting for me. I'm like the new guy here. For those of you who don't know me, for some 44 years, reporter, anchor at the CBS station in Washington. I retired in December. I belong here. I'm a recovering cancer patient. I'm a recovering heart attack patient, and I'm a staunch advocate of healthy lifestyles for for my people, for African Americans. I've done a lot of work with the Association of Black Cardiologists. We've done documentaries and that sort of thing. So you're speaking my language. I'm honored to be here. And as a television news reporter and anchor, one of the things I don't like to do is stay on the stage and have the camera on me too long when I don't want the camera. So I want to get some answers. Health disparity, nothing new. The news story that we've learned is that it's worse than we could have imagined. And COVID has peeled back the layer and taught us those things. So I want to bring in our distinguished panelists. You know a lot of these people far better than I do. Dr. Shariki Kumanyika, everybody knows she's research professor, community health and prevention, Downside School of Public Health, Drexel University. She's professor emerita, epidemiologist, University of Pennsylvania, and founding chair of the Council on Black Health. Also joining us this afternoon is Dr. Brian Smedley. Brian is Chief of Psychology in the Public Interest American Psychological Association. Also joining us, Dr. Rhea Boyd. Rhea is pediatrician, child health advocate, Palo Alto Medical Foundation, UCSF Children's Hospital in Oakland, California. And then finally, Ms. Margaret Anadu, she's partner, global head of sustainability and impact, Goldman Sachs. I want to start immediately with a question. It's kind of like what I do. Again, health disparity, nothing new. A lot of us feel as though, you know, there's been enough talk. Now we need to talk about action. Now we need to talk about what exactly can we do to level the playing field and get some of our people healthy. Dr. Kumanyika, I want to start with you. What needs to be done like yesterday?
Thank you. The opportunity to contribute a bold idea is very much up my alley, because I've said something that we use as a tagline: achieving health equity for Black people is possible. And so, how do we do that? So my theme is we should reimagine Black health through food justice. Food justice could be defined very broadly to include all aspects of the movements that you see now, of making sure that Black people have access to foods that are desirable, but also good for them. And so when I talk about healthy food, I'm talking about foods, leaving aside some of the foods that are high in fat, salt, and sugar. I just have this one slide as a background for what I'm talking about, and you'll figure out what it means as we go along. So food is a basic human right. So I'm linking this to the Black Health Bill of Rights. And we have the right to have food that will help us to thrive. Why is this a bold idea? And it's a bold idea because the data show that the food system is unhealthy for everyone. I mean, across the globe now, but the companies, food manufacturing companies, some restaurant companies are making their profits off of food that is the unhealthiest, it's the most profitable. But in Black communities, this is more heavily targeted to us. So it's racially targeted marketing, which means that we are subject to people having imprints of unhealthy foods really thought of as a part of our culture, as a part of our psyche, as where to go for comfort. And I think that when you look at these books that have been written about specifically certain food companies and Black people, you realize that this is not an accident. It's not what you see, what you see in your community may not be an accident. This is all very carefully cultivated and curated so that we see companies as entrepreneurial opportunities, as employment opportunities, as opportunities for funding of our community action. So I think this idea is bold because it would be taking on big systems, taking on systems that won't be figured out for a long time, but in terms of how to improve them, but we can't wait for the powers that be to figure this out and then tell us what to do. And Bruce, you mentioned, having conditions that are associated with diet. So if we take this on, it's bold. It's also very bold because this is not what you want to hear. So I'm looking directly in the camera. Nobody wants to hear that they're comfort foods, they're nurturing foods, the things that the things that they can go to short of controlled substances should be changed. And so the idea, as I'll conclude just with these brief remarks, is not that we would try to put people on a medicinal diet or something like that. We should own our heritage, our needs, think about how we can do something different We can watch the door of what's coming into our communities. That was a comment that one of our study participants made. Nobody's watching the door about what's coming into Black communities. It's all coming in and it's not good for us. And join with the people who are involved in other aspects of food justice and do something about this. This is a day-to-day, 3 times a day problem for Black communities. And if we can't face this one, I don't think we can reimagine Black health. Thank you.
Dr. Smedley, let me ask you to comment on this. And let me preface this question with, I was in Harlem one time, and an African-American doctor was talking to a group of women clearly battling obesity. And she was trying to get them, to change their diet, their eating habits, their food selections. And I noticed she started to get some attention when she said to them, if you don't want to do it for yourselves, do it for your children. What happens to your children if you get sick and ill and you can't be available to them? And I noticed that they perked up and they looked at her. She had their attention. Is it perhaps how we're approaching this, as opposed to just saying, don't do this, do that? Should we take a different approach to try and get our people to change their food choices?
That's a great question. Thank you, Bruce. First, I want to thank the Council on Black Health for having this very important conversation and for talking about what's foundational in terms of rights and the right to health. So I thank and congratulate the Council of Black Health. Your question is so interesting, Bruce, because in this country, we tend to individualize health problems that are fundamentally structural. And Dr. Kumanyika has talked about some of these problems, the heavy concentration of vendors selling unhealthy foods in communities of color and deliberate targeting of advertising to communities of color, particularly kids of color. The fact that we have limited nutritional resources. These are the kinds of things that we need to elevate, even as we're talking about the responsibilities that we have to ourselves and to others. Of course, we want to ensure that our children see those of us who are parents eating healthy foods, and to instill that sense that we are in charge of our health. And that's important, but that tends to obscure the role of our history, the role of our government. Many of the underlying problems that are foundational to what Dr. Kumanyika is talking about and to what Dr. Jones talked about were in fact created. We as a government, we have as a society have created health inequities through policy and practice. Some of that is related to historically government's role in creating separate and unequal neighborhoods, separate and unequal health systems, separate and unequal school systems. These are the structural problems. This is racism operating. To follow on Dr. Jones's brilliant talk, naming racism in those systems is as important as communicating what our individual responsibilities and choices are. So I advocate for comprehensive approaches. We certainly need to reclaim our own power and authority and agency as individuals, but we also know that part of that agency is the kind of advocacy and collective action that Dr. Jones talked about to change those systems and structures that create inequity in the first place.
Sounds like we're talking several lanes here, and we can do many things, at the same time. I want to talk about government because whenever you talk about government, it's big, it's fast. If you can put a face on it, people can relate to it. But as long as we're just talking government and institutions, it's big for a lot of people. Too big, can't do anything. Nothing's going to change. How do you address that?
Sure. Well, the first thing I would do is to draw upon one of the lessons that Dr. Jones frequently imparts, and that is that we have to be correcting historical injustices. So yes, government is complex. Government is enormous. It's a huge ocean liner. It's hard to turn that ship. But when we recognize the fundamental role of government in helping to create these inequities, it creates a moral imperative. It creates a case for repair for the actions that government has done to, in fact, create the inequities that we see in health and well-being. So yes, you are right. There's so much that needs to be done, but we can start locally. We can start with local decisions around things like land use, zoning. Too often, communities of color are overrun with environmental health threats as a result of poor zoning policies. To speak to what Dr. Kumanyika was talking about, there are local jurisdictions who are recognizing that food deserts hurt all of us. So they are taking steps to put a moratorium on the siting of new fast food restaurants or other vendors selling unhealthy foods, and are creating incentives for grocery stores, for sit-down restaurants selling nutritious foods to come into our communities. And this is the kind of local activism that we can all be engaged with.
Dr. Anadju, the private sector, where's the responsibility? Where are people and institutions stepping up in the private sector?
First of all, thank you for having me. And you said Dr. Anadju, and I wish I was a doctor, especially during this conversation, but I'm not. But thank you for having me as part of the conversation. You know, it pulls on some of the threads that I've heard already about sort of, you know, individualizing things that are issues or et cetera, that are actually much more systemic, much more structural. And so one of the things that we focused on at Goldman Sachs is sort of how our deployment of capital, both our commercial investment capital, but also our philanthropic capital, how we can work holistically around some of these issues. So just back in March, we launched an initiative called 1 Million Black Women. We have a bold, but we think highly achievable goal of, you know, investing $10 billion over the next decade to narrow opportunity gaps for at least 1 million Black women. So we started that work with research. We're incredibly data driven. We wanted to be clear that while we have the intention, the resources, the commitment, that Goldman Sachs does not, you know all of the challenges and solutions for Black women. And it won't surprise, you know, anyone on this call, but a significant amount of that research was devoted to healthcare, and not because we started with the goal of focusing on health. We started with the racial wealth gap, but because of how cumulative all of these issues are, you know, one of the pieces of research that actually surprised me, or data that came out of it that surprised me, you know, is that Black women are 35% more likely to cite healthcare as a barrier to work. And so an entire piece that started out about the 90% wealth gap, and then of course you start to break that down, you know, 2/3 of that wealth gap is a wage gap. Well, when you're then exploring wages and you understand for Black women, you know, it's not just about the fact that we make 63 cents on the dollar compared to white men. It's also the fact that our, you know, our labor participation percentage relative to white men is 10 points. So it's sort of a long train back to that, again, you know, 35% more likely to cite health care as a barrier to work. But it just drives home the point that we can't focus on, you know, kind of racial equity, gender discrimination, economic mobility, really any of these issues without talking about healthcare. But then, of course, vice versa, we also can't really talk about making a difference on health without a focus on, you know, housing, education, you know, digital connectivity, all of these things. So our focus, and we are, you know, we've had a lot of debates internally about whether, you know, we've taken the right approach in being so broad in what we're doing. But we've also decided that we need to be kind of, you know, honest and genuine and credible in the work. And there's no way for us to focus on really just one of these pillars without identifying and being clear about the fact that they are cumulative and they are interrelated. So we're focused on healthcare, but the other 6 pillars are education, housing, workforce and wages, digital connectivity, financial health, right? There's a lot around the financial decisions we make, of course, around, you know, what drives our health. So, you know, we're just getting started. We announced again, as I mentioned, three months ago, but I would say one of the more powerful pieces of the initiative that we've been engaged in over the last 3 months is really just the profound respect you can pay by just listening. You know, there's a lot of talk around certainly, you know, health disparities, but, you know, Black women more broadly and Black people more broadly without, you know, discussions like this where you know, and I'm just obviously humbled to be on the call with these experts, but without asking us and like actually centering our voices in those discussions, because, you know, for our specific initiative around Black women, we feel pretty strongly, Black women, we understand our challenges, we understand our solutions, no one asks us and no one listens to us. And so really the first part of the initiative has been, you know, we've had, you know, 5,000 person listening sessions. We've had, you know, 1, 10, 15, you know, person listening sessions, but all with really just understanding within these pillars where we could be focusing, you know, both tactical solutions and investment ideas that people have, but also more broadly where we should be focusing. And so we're off to a great start, and you know, I think we're going to drive pretty meaningful impact.
I spend a great deal of my time as a reporter going where people are and telling people's stories, and all this great information that I'm hearing here. You know, I want to see this at some point in time put in the form of people's stories that people can really relate to it. And one of the stories that came out of COVID and the pandemic with, that I want to throw out and ask all of you to address, and there might not even be a specific question attached to this. We go into COVID and we discovered, soon as we get in there, that a disproportionate number of African American people are contracting, the virus, the disease. A disproportionate number of African Americans are dying from the illness. And what we heard almost immediately, and if one journalist of reputation reports it, everybody, I call it lazy journalism, they start reporting it. But then eventually we found out that there was a lot more to it. For example, we were the frontline workers, and that's where we were also contracting the illness. We also lived in multi-generational homes. We couldn't quarantine if somebody was infected, while hotels and motels downtown sat empty. In Israel, for example, they opened up all the hotels so they could get people out of these homes, low-income homes, so they wouldn't infect everybody else. I want to ask you guys, have we learned from the pandemic, from COVID? And will we see things done differently? Are we preparing for the next pandemic? Are we preparing our people for the next pandemic?
I'll say just, I think halfway, right? So there's information, and then there's what you do with it. Even the concept of essential workers, and sorry, I have such a Black women obsessed lens these days, but the idea that Black women are disproportionately nannies, healthcare workers, educators, bus drivers, 25% of public sector workers in the US are Black women. I think that's something that certainly within my both personal and professional community is not a surprise. That was not news, but I think COVID and the conversation has given language to it, given focus to it. Like, none of us were really talking about essential workers or what that even meant or who that was years ago. I think that your question about whether we're going to see change is like, okay, well, now that we know that a massive sector of our economy, which we actually need, that are essential, that drive us, that get us through our days, are at incremental risk in a pandemic, are the lowest paid. Like, now that we know all that, well, what do we do with it? So I think we're not far enough along to know. I would say there's certainly encouraging signs. I think so much of what's coming out of the federal administration, if they can get it done, is encouraging. I think there are many, commitments and pledges and initiatives coming out of the private sector, but it's early days. Yeah. It's early days.
What do you think, Dr. Kumanyika?
I'm sorry, I didn't know if you were addressing me. I was reading the chat. So, I think that one of the things we have to avoid is the workarounds that seem to be such feel-good things for the public in general. Seeing people in food lines and hearing about all the meals that are being distributed is way, way downstream from where we need to be with the solutions. And so I think if we take this information and we put it together, food insecurity has gone up tremendously during this period. A lot of it does come back to income. It comes back to income factors that are driven by race, by racism, not by race. So you can't avoid race as an influence on your opportunities. And so I think we need to start there. To go back to what Kamara was saying in her presentation, we have to recognize that it's not just low income or being a service worker for Black people. This is a part of a systematic treatment of Black people. And so I think we need to expose some of those things and then address the solutions and steer people away from these workarounds that just keep us in our place, so to speak, that make us say, okay, they're in their place, they're in the food line, they're here, they're not leaders, they're not doing other things, and really look at it in a holistic way. But I think racism is really at the core of a lot of these other problems that people feel more comfortable perhaps focusing on, but you can't isolate them from the racism.
The other thing I'd add here is that, the reason that Black folks are disproportionately affected by COVID is because, like many have noted, like Black folks are disproportionately exposed and less protected. And both of those factors, higher exposure and less protection, is a structural reality. It's something that's been institutionalized in this country that our government could do a lot to address. And Dr. Smedley already touched on the ways that we should think of moving our government as approachable, but I'll also highlight for people to look at what's happened just over the past year. Our government has poured billions of dollars into people's lives. States have vaccine lotteries. The vaccine is entirely free. Every American lives within 90% of Americans now live within 5 miles of a COVID vaccination in a way that people have never lived proximate healthcare ever. We have a new child tax credit. We have eviction moratoriums. Our government has said, because of the impact of the pandemic on our economy and on people's lives, we are going to invest in it. And so that's a sign that actually the government can move incredibly quickly with enormous resources to address the urgency of the problem. But what we don't have is the political will to do that long term. What we don't have is the political will to say, in addition to living within 5 miles of a vaccination site, you're going to live within 5 miles of a primary care clinic. And just like that vaccine was free, visiting a doctor is free. Going to the hospital is free. Intensive care is free, right? We in this country need a long-term commitment to universal health care, to universal child care, to making the things that have impoverished Black folks because they've kept it from us and charged us more for it over time, to making those things completely free for everybody. But because the folks who are most low income tend to be Black folks. There was just some data that came out from Brookings that told us that Black folks, 1 in 5 Black folks are in their 3rd generation of poverty, compared to 1 in 100 white folks in this country. The concentration of poverty in our communities is absolutely a result of structural racism and the way the government has not taken affirmative actions to make sure that Black folks can reap the same economic benefits as other communities. And so I think we can look at the example of what we've done during the pandemic to say the government's willing to do it. We just have to make sure they're willing to do it for the long haul.
30 seconds, sorry, just to underscore your point. When they came out with the vaccine and it was made available, it wasn't an issue of do we have enough? It was how do you get the vaccine to the people who want it? You had to go on your computer, your laptop, your cell phone, whatever. You had to make an appointment. There was a place called Bread for the City in Washington, D.C. It's one of these nonprofits that services low-income working people and poor people. It was one of the sites where the vaccine was immediately made available. On the day that they opened their doors to administer the vaccine, there was nothing but white people who showed up for that vaccine. And it's because they got to the computers, they had their transportation, they knew how to use the computers, they knew how to network, and so they were making appointments, not just for themselves, for their friends, and family, which is all fine, but the Black community, the African American community, didn't have that kind of access to computers, laptops, cell phones, transportation. So a friend of mine happens to be white, shows up at Bread for the City because that's where the city center. She got an appointment. She calls me. She couldn't believe. She says, "Bruce, where are the Black people?" She felt so guilty about it. She made a $500 contribution to Bread for the City. And then the city started to dial back and started to do things differently, okay, in terms of how to make the vaccine available. These are things that probably cause even more people to contract the virus, maybe even die from it. And that was startup, and those decisions were made not by private sector, white people don't know where they are. These were Black officials, not blaming them. I'm just saying we keep doing the same things, making the same mistakes, regardless of who's in power. I'm hoping that doesn't happen again. As a matter of fact, I know it won't happen again because we've learned from this. But it was very, very costly, not just here, but in other cities and throughout the country. I'll leave it at that and just ask you guys to pick up on that in terms of what have we learned? How will things be differently?
Can I say one point on that? Oh,
sure. Yes.
So in partnership with Kaiser Family Foundation and Black Coalition Against COVID, we have been leading one of the largest national campaigns to talk to Black folks about the COVID vaccine. So we actually know a ton about Black folks who have gotten vaccinated and those who have not yet, or those who say they're still waiting to see more data before they decide to get vaccinated. And among that group that's waiting to see, more than 70% say that they want to hear from a regular provider that this vaccine is safe for them. But we know that Black folks in this country are least likely to have access to a regular provider. They don't have a clinician that they can go to when they need advice, and they don't live close to a regular clinic where they could go to even get the shot if they wanted to. So now they're going to have to go somewhere they've never been to get medical care. As you pointed out, there are structural barriers to getting there. Childcare needs, transportation needs, the cost of parking when you arrive, bus fare, right? It's never free to just show up at a clinic and to get home from that clinic. And so there are costs, even when the shot is free, there are costs to you coming and going in between getting that shot. And so folks have raised concerns about that shot. What then comes on the news is people are still concerned that it's not free. People are worried about costs. And what we miss is that there are so many hidden costs of obtaining healthcare in this country that Black folks in particular are uniquely burdened by. And so what we have to do to overcome that is, again, structural interventions, some of which the federal government has attempted to do, right? Partnerships with rideshare so that people can have free rides, making sure that we bring the shot to you through mobile clinics or at your local pharmacy that might make it more available, free childcare, et cetera. But we have to acknowledge is that we never built a national healthcare infrastructure that made obtaining healthcare accessible to everyone, especially Black folks. And in some areas, even during the pandemic, we actually shut down the hospital and clinic in your area because they weren't able to operate under the cost of COVID. And so we have to talk about what it needs to build up the type of infrastructure it actually takes to get healthcare to everybody, which people may be shocked to find is not just making the shot free.
Anybody else on this?
Yeah, can I just have one thing? Because it's just a fascinating point. Almost sort of the point that you were making earlier, Rhea, just about sort of like, us thinking, the government can't move fast enough. They can't move quickly enough. And yet we've seen, right, this incredible investment, if you will. The problem with that, of course, is that you pour in some ways, whether it's free vaccines or, what we saw even with, the PPP loans for small businesses, when you do move quickly and you allocate that level of resources with that level of speed in a system that is already faulty, that doesn't have like an equitable infrastructure to like take it and distribute it well, it's like you have this kind of dissonance of like, well, the vaccine's free, we have PPP loans, like we're doing all these things, but if it's sitting on top of a foundation that's faulty or doesn't have the infrastructure to distribute it well, provide information, deal with all the hidden costs, I think that speed actually becomes even more of an issue. So anyway, I struggle with that.
And I'd like to build on those comments, because I think for today, what we really want is what did we learn? What can we learn from what was done during COVID? It wasn't that the system couldn't do it, it was that the system wouldn't do it unless it was a crisis. But I wanted to tell one story that's been very popular, at least in Philadelphia, which I think has lessons for us. So a colleague of mine that I've known since she was a medical student got out in front of vaccinations when they weren't available in Black communities. And she started Dr. Ella Stanford, she started the Black Doctors Consortium. I think when you're talking about people not having a primary care access, Dr. Boyd, you're mentioning that we need to think more about what can we do ourselves, because Dr. Stanford, she's a young, spunky woman from North Philly. And she said she got tired of hearing people talk about what wasn't happening. And she just said, wait a minute, I can do this. I can do this. I'm a doctor. I know the whole story. I can do it. What else can we do rather than waiting for the system to provide that primary care doctor or to do that? We need to feel like we have more control over what's happening. And I would love to hear your thoughts about that.
I can tell you one thing that we've done. So knowing that Black folks don't have access to primary care providers, we are going to people in your communities. Right now, we're doing these teletown halls that began during the census outreach with some of the organizations that were founded by Stacey Abrams called Fair Count, and is led by her sister, Janine Abrams, to call people up. We call 200,000 people. We have another call tomorrow in states across the South. I was just speaking in Louisiana, where they have some of the highest rates of COVID right now in the world. And we're talking to people online. It sounds like you're on the radio a little bit, and we're doing it because people don't have equal access to the internet. In the South, 1 in 10 folks don't have broadband internet access. And so we call people, they stay on the line, and we answer their questions. we have been shocked to hear, honestly, or very surprised and pleasantly surprised to hear how people will call in for other family members. They'll have their entire family on the line and pass the phone to other people, and how specific people's questions are, which just underscores for me that Black folks just need to hear from a provider. They need to sit across from somebody and say, I have diabetes, I have heart disease, I take this medicine. Is it still safe for me to get this vaccine? Which is also why I've been trying to shout over the news waves. And I have an article out actually in the Nation today that I'll link for people who also want to share this argument, that Black folks have legitimate concerns about the vaccines. When it comes to Black folks, and this is true of Latinx folks too, and our resources are available in Spanish, and Afro-Latinx folks, when it comes to getting the vaccines, people aren't anti-vaxxers. They're not averse to medical care. We've never not wanted medical care. What we want is care with dignity. What we want is people to respect the fact that we have questions and we scrutinize care before we receive it. And so when people call in, we encourage their questions. We say, thank you for putting us on the spot. These are excellent questions. You should always ask them before getting any medical procedure, and then we answer them. And then luckily, because of the resources that we've had from Rockefeller Foundation, we sign people up for vaccination right there. So to your point, knowing that this would happen, knowing that we have information gaps and that people would not be well captured in this vaccination campaign, Black folks, Black clinicians, and I have been working for 7 months to make sure Black folks have this information right in their communities.
I think that is so important, respecting these people. Too many times it's something for them regarding public safety, health, and whatever, without their input. One of the most powerful things I heard one of the contact tracers say to somebody at the other end of the phone during the crisis, now what can I do for you? Translation, what's on your mind? What do you need? I just think that is so important. Thank you very, very much for that. I don't know how much time I got left, but this has been incredible, this discussion. Are there any other points that need to be made? You know, because I don't want people to walk away thinking, you know, we missed this, we missed that. Is there another point or two or three or whatever that we need to make at this point? Because you guys have been absolutely great.
I'd like to make a point, Bruce, if I can, and this is outside of the realm of government, but it really speaks to us as a society. You're so right that when COVID hit, this was an inflection point. I was very hopeful that the nation would hold a mirror to itself and see itself for as it truly is. We are a nation deeply divided. When COVID hit, we saw all kinds of anti-Asian xenophobia. We saw the usual racism against Black and Brown exacerbated. COVID, like other pandemics, has exacerbated divisions that exist. And in that way, we have an opportunity to see how our fates are intertwined. Unfortunately, that lesson, I don't think, has been recognized as widely and broadly enough. I can illustrate that lesson very simply. Societies that are inequitable have the worst health for everybody in those societies. At one point during the pandemic, the US, with about 6% of the world's population, had about 30% of the world's mortality due to COVID, despite having what some people think is the best healthcare system in the world. Now, it's clearly not. If you look at objective indicators, it's the most expensive easily. But the problem has been that our social division has made it difficult for us to emerge out of the pandemic healthy and well. When you have the kind of division and distrust that we have, societies become divided. And it becomes very difficult for people to know who to trust, what information to trust. It becomes difficult even in the example of many Asian Americans who anecdotally said, I don't even want to go out to get the shot because I'm fearful about the kind of racist vitriol that I might be subjected to. So I just want to add that point in, that one of the lessons that we repeatedly fail to learn is that the kind of racism, xenophobia, and other sources of division that are so characteristic of the United States actually hurt our pandemic response. And I would submit further deepened the pandemic in this country compared to other countries.
Is it a problem coloring everything in terms of race? What about class?
Absolutely. Class is a fact. There are so many fault lines in the United States. We have widening wealth and income gaps. We have, of course, deep racial inequality that's gotten worse as a result of COVID. We have rampant misogyny in this society. We still have transphobia, homophobia, all of the sources of social division that make us a weaker and less healthy country.
Dr. Kumanyika?
Yeah, I just wanted to make this one comment about the class issue. There's a good line of work, and I'm a researcher, so I'm always going back to the literature. There's a good line of work that talks about diminishing returns of income, education, and the things that you would associate with upward mobility for a lot of different reasons, which I don't have time to go into, but I think we have to keep that in mind. Black people at a certain level of professional education are not being paid the same way, and they're not being treated the same way in the system. So we have to look at how social and even upward mobility is known to increase stress for a lot of Black people, because it puts you in an all-white situation sometimes and other things where you have a different set of worries. And so I hope we can keep the race and the class. It's very important, but it doesn't work the same way for us. That's my point. I agree with Dr. Smedley, but it works differently for us because people put that color lens on it and they don't see the same thing as they see a white person in that same social class.
Yeah, I agree wholeheartedly. And I think that's something that I think probably Black people certainly probably just anecdotally appreciate, but even the data bears that out fairly clearly. Like if you look at wealth gaps and by race, and then you stratify them by either sort of higher paid sectors, by educational attainment, you know, our wealth gaps and even our wage gaps, they don't increase, they increase quite substantially. So the biggest gaps that you'll see between, like in finance, just for one example, between Black professionals and white professionals is at the more and more senior levels. So it is imperative that we continue to focus on both. Even in healthcare, I feel like the maternal mortality stats for Black women is one that I think is very gripping because it's so tragic and it's so personal. And we see those gaps for, and Dr. Boyd and all of you will probably have the exact numbers, but I think something like the maternal mortality rates for a, high income Black woman with a master's degree is about the same level as, I want to say, a white woman with just a high school degree who's lower income. So this is about class, this is about race, it's about both. And class certainly does not solve it. It helps, but it doesn't solve it.
Where are we hopeful? Where are we hopeful? Where are you seeing signs that there's a breakthrough, that it's going to get better, that our numbers are going to go up, that we're going to live longer, we're going to be more healthy? Anybody hopeful at this point?
I'm very hopeful that this moment, as we're calling this session, is a moment when we can call on ourselves to think differently. Like the white community is being asked to think differently. Are we being asked to think differently about what we can do ourselves? And I think that that's happening. And I'm always hopeful. We can't ever lose hope, because that's then we just become victims of the narrative.
Let me get you to weigh in on this. And here's an area where I really become concerned. Got a lot of affluent, friends, African-American friends, a lot of education, a lot of income, a lot of status, fraternity brothers. End of every frat meeting, they go to the back and they're smoking cigars. Had a friend that I've known for years who was one of my best photographers out in the field. We risked our lives together. I didn't know, still smokes. I buried a friend a couple of years ago. Jim Vance, big time anchorman here in DC, continued to smoke. 30 years ago, he convinced me to go to a hypnotist to stop smoking. It bothers me, especially when I see those of us with the information, have seen the examples, we've buried friends and this sort of thing, but we still go to the comfort food. We still go to the other comfort devices. Doctor, what do you say to us? How do you get, and we are the examples, other members of our families, communities, they look at us. What do you say to us, to get us to think differently, to behave differently, to be more concerned about our own health?
I would actually turn that on its head a bit.
Dr. Boyd to answer too, so please.
I would turn that on its head. I would say, if you are somebody who is eating foods that aren't actual foods, that don't have nutrients in them, it's because those are the foods that are available to you. And you're doing what you need to have the energy you need to work and care for your family. If you're somebody even who smokes marijuana as a way to relax and cope with mental distress and the stress that comes with racism at your job, I understand that you're making those choices inside the structural constraints that surround your life. And so my work isn't to blame you for those choices. It isn't to shame you for those choices. It's to say, we as a community have to acknowledge that our choices are constrained and there are things we can do to make sure we all have the resources to live healthier, longer lives. Those things truly lie with pushing public policy to ensure that everybody has access to healthy food in their neighborhood, to ensuring that everybody has access to a living wage, to make sure that every job in this country comes with paid sick leave, comes with healthcare benefits, comes with things that allow people to make choices that could be healthy for them.
I would
My
I
answer-
push
my
back
answer
just
is-
a little to say, as long as you've got your health, you've got a shot. And that's what I say to those friends of mine that we've been talking about. But I'm sorry, Doctor, go ahead. You were going to say something.
I think that we should do more research on those issues, because what I would say to your point is that it shows this concept of dimensionality and life course. I have the life experience of a little Black girl in a segregated school. And that's the privilege of age when you're from below the Mason-Dixon line. I'm also was a tenured professor and at the University of Pennsylvania and a member of the National Academy of Medicine. Now who walks into the room when I walk in? That little girl is still there. I can be turned into that little girl in a minute by the way I'm treated, by the agency I feel. And I think your colleagues are showing you that education isn't enough. The higher income, we've just said it has diminishing returns. We can't only focus on people with limited resources. We have to focus on all of us, because we are all subject to racism in ways that hurt. And so I think we need to find ways to help people see things differently.
Okay. Anybody else? Brian?
Well, I think that's exactly right. I mean, there's abundant research now showing that racism in itself is a stressor operating at multiple levels. And so people cope with stressors in different ways. There is a burden associated with racism related stress that is over and above the stresses that the average white person might face. So when we see coping behaviors, as Dr. Boyd said, it is within a context of the options that we have available to us. We need to, as a community, empower ourselves to be working toward healthier coping solutions while acknowledging that there is that additional burden of racism-related stress, and that ultimately we need to dismantle those sources of stress, even as we're working to empower individuals, families, and communities around healthy coping.
Can I say one more thing there real quick?
Sure.
The other thing I'll say is you can't out-earn racism. So we were talking before about class, and Dr. Kumanika has been so clear about the diminishing returns for folks as they ascend to higher levels of education and higher levels of income. But in some indicators, it's not just diminishing returns. Like for maternal mortality and preterm birth for Black women, actually the more education you have, particularly after college, and the higher your income is above $150,000, the more likely you are to have preterm birth. That tells us something about the type of racism people experience in certain working environments and the type of racism they had to experience as they went up the ladder. And so we also have to understand that even if you have a great income, even if you work in a job with healthcare benefits, it still doesn't supersede the way that you are treated day to day in every space that you pass through as a person wearing Black skin who's racialized as Black. And so that's also something that we have to independently address, on top of also trying to make sure that people have the resources they need.
Right. Where does this conversation go? Where do we take this after today, after this moment? Who needs to see and hear this conversation?
I'm encouraged about the potential to organize stakeholders, all of us, around the agenda that the Council for Black Health has laid out, and to come together around this Bill of Rights, to assert our rights and to build a grassroots movement. Dr. Jones spoke about the anti-racism campaign. These are interconnected movements that we need to begin to build upon. We have the tools, we have the moment, the opportunity. People are talking about systemic racism, even though in many cases they don't know what that means. But the point is that some folks are open to being educated and to creating the kind of change that we can only create with a common agenda like the kind that we're talking about here.
Let me ask you a look into your crystal balls. How much of an opening do we have here? And I think somebody alluded to this earlier. After Barack Obama, was elected, and you saw this surge of anti-Black, movement coming on. And it may be, and then Donald Trump, he came out and he told everybody, he was elected because of Barack Obama. And you can see some of the support for Black Lives Matter and some of these other movements waning already. So how long is this door going to be open where the masses, the majority, the government, the politicians are willing to, private sector, willing to listen and act on what we're talking about here? Is it a window of opportunity, or is it much bigger than that? Are we talking about a 4-lane highway here where we're going to be able, to drive down with these messages, these ideas, these plans for quite some time to come? What do you guys think?
Well, first I would say we need to push the door open, right? You are so right that there will be powerful forces that want to return us to the status quo, and we're not going back there. And so I think we need to push the door open. That's one. And then recognize that with every political advance, there is the pendulum swinging back the other way. We've seen that very clearly. You alluded to this, Bruce, the fact that we have powerful political forces now who are very afraid of the changes that are happening in this country. A much more diverse and pluralistic society that's intolerable to folks who prefer the status quo of white supremacy. So what's positive to me and what's on our side is momentum, and the fact that increasingly younger people are rejecting old notions, rejecting the status quo, and are recognizing that the status quo inequality hurts all of us. So I'm convinced that this new generation, people in their 20s, 30s, increasingly are moving us in a positive direction. We need young people and their ongoing leadership to help to continue to push us so that we can address the backsliding that inevitably happens when we take a step forward.
Yeah. Margaret, I know you're not a doctor. Okay, we cleared that up. What do you think? Weigh in here.
I think I have a lot of thoughts. I would say, and part of this is just from my lens on this as an investor. I think what we need to see right now to continue and to sort of not, go down the wrong path is, like, one, we have to see tremendous activity and response. I do think we have a considerable risk that it's 3 years from now, 4 years from now, 5 years from now, we get through COVID, we manage to some level of what it really looks like to just sort of live with the pandemic. And that if we don't do anything, it's sort of like we've all just desensitized even further to just all of the just structural racism and how that impacts just sort of every moment of our lives. I would say in terms of, I'm optimistic, cautiously, and for a few reasons. Dr. Boyd talked about sort of even just, the hidden cost and disproportionate burden of even things like childcare and how that can impact access or not. Those are things that we're talking about right now in ways that we haven't in a long time. Child tax credit, money for childcare, actual, even just the physical spaces for more training. Those just weren't conversations that we were in, or at least from where I sit as an investor, because all of these places have capital holes. Where there are healthcare deserts, there is also a desert of capital to make a healthcare facility. Where there is a lack of diversity that we need to see across actual medical professionals, there's a dearth of access to capital for those individuals to actually obtain that education, obtain the specialties they need, et cetera. So I would say, one, on the negative side, I think it's deeply urgent. I think if we don't have big structural, and I lean very much to the government end, even though I have a private sector seat, of investment in these spaces, in education, in wages, in healthcare, I think we do face a pretty significant risk of being societally even more okay with just the ridiculous structural inequity that we've all been sort of living with and dealing with for decades. And so I think it's deeply urgent, but I am hopeful.
This has been one
And-
incredible conversation. Margaret, Ria, Brian, Shariki, thank you, thank you, thank you. This has been awesome. Going to turn it back over to you, Mr. Carr.
All right. Thank you, Bruce. That was awesome. That was a great panel, a great conversation. We needed even more time. I will ask the panelists if they get a moment, maybe to go through the Q&A section on the bottom of the screen there. I know we had a couple of questions in there, and even if they get a chance to scroll back through the chat, there were some kind of questions and some information and some back and forth data in there as well. So it might enlighten some people. We can definitely continue the conversation in the chat as well. So thank you again to the panel. We've heard examples of really bold action. We heard a plan from Dr. Jones that included 8 action items, and we've been challenged. But now it's time for you to talk. The next segment is designed for you to reflect on and react to what you have heard so far, and to identify some opportunities for action that the council can take and that we all can take as well. All right, so here's what's going to happen. A little bit of instruction here. We're going to be switching platforms for the next segment. You should have the link in your meeting materials that you received via email. Now, the links are also going to be in the chat box as well. We're going to give you an opportunity for facilitated discussion around bold actions. And after about 15 minutes, we'll have a quick 5-minute break, and then you're going to have the opportunity for some more discussion depending on how we're looking on time, okay? So we need to hear your voices, so please join us in the breakout session. Don't forget, we're going to meet right back here at 3:15-ish for a debrief on the discussion. And our closing keynote speaker is on the way, Dr. Freddie Haynes. You do not want to miss that. So let's move on to the link for the breakout room right now. Okay, our final keynote speaker of the afternoon is Reverend Dr. Frederick Haynes III. Now, you can read Reverend Haynes' full bio. It's in your workshop materials, so make sure that you do check that out. Reverend Haynes is the senior pastor at Friendship West Church in Dallas, Texas. He is a prophetic pastor. He's a passionate leader, a social activist, an eloquent orator, an educator engaged in preaching the gospel of Jesus Christ and fighting against racial injustice. So we've been talking about reimagining Black health through bold and courageous action, and we have a bold speaker for you this afternoon. We also have an action plan, and we have our work cut out for us. Reverend Haynes is going to close us out with words of encouragement to keep us strong for this journey. Again, before we get started here with our final keynote address, feel free to drop your questions, your reactions in the keynotes Q&A box, okay? So there's 2 things happening. We're going to have what's happening on the screen from Reverend Haynes, and then there's going to be a whole different set of things happening in the Q&A session. So make sure you keep the conversation going in both places. We're going to multi-purpose here, okay? And we'll get to them at the end if we're able to, if there's something that needs to be addressed. All right, everybody, a warm virtual welcome right now to Reverend Haynes. Reverend?
Thank you so much. Let me express my appreciation to you for that gracious and kind introduction. I am honored to share during what I can only imagine has been a profound and powerful, I would even say game-changing conference. Dr. Jones is one of my sheroes. I missed her, and I hope that I will get a chance to get the link so that I can hear her, as well as all of the other gifts to our community that have presented today. I must give a shout out to my sister, the Reverend Siobhan Arlene, for her wonderful work and for being the plug, connecting me with what you are doing. So thank you so much for this opportunity to share with you, and especially as we discuss such a profound and powerful subject, leading the charge for realizing healthy communities in this moment. I want to get at our theme in a way that I hope will be creative, but at the same time, mentally and spiritually stimulating. I'm going to, in your hearing, share with you an open letter to the former Surgeon General, a prescription for healing our Black communities. The United States Surgeon General is considered the nation's doctor. Dr. Jerome Adams served in that position during the last presidential administration. He was the fourth African-American Surgeon General and the second Black male to hold this prestigious position. During the early weeks of the coronavirus crisis outbreak in the United States, we all know that Dr. Adams was a prominent voice and presence during the daily coronavirus press briefings with the former president. As the unpredictable, invisible enemy, COVID-19 was wreaking havoc and heartbreak on a nation that was woefully unprepared because of an inept federal response, the data revealed that the virus was disproportionately killing Black people. COVID has been a mass murderer that placed a bullseye on Black, brown, and poor communities, and bad policies, past and present, have been complicit. I won't forget April 10th, I should say, 2020, PBS White House correspondent Yamiche Alexander posed a question to the Surgeon General about the incommensurate and inequitable way that the virus was victimizing Black people. The response of the Surgeon General, for me, was offensive and inconsistent with the message he had shared earlier that week. Adams struck a note of condescension toward a hurting community and prescribed personal responsibility as the treatment plan for a community that was being tested least while dying most. Listen to what Adams said. We need you to understand, especially in communities of color, we need you to step up and stop the spread so that we can protect those who are most vulnerable, he lectured. He urged members of Black and Latino communities to refrain from alcohol, drugs, and tobacco use and to adhere to federal shelter-in-place guidelines. In these moments, I want to use this response of Dr. Adams and the breaches exposed by the coronavirus crisis as a metaphor for the scientific racism and medical apartheid that have infected Black communities while blaming Black people for ill health. You see, Adams represents those transactional gatekeepers who guard a white supremacist structure that allow the coronavirus to further reveal just how sick this nation is. I'm going to offer a prescription calling for the abolition of medical apartheid, the valuing of all humans, and the creation of healthy communities that will go a long way to building structural immune systems in our body politic that will make all of us safer from death-dealing viruses. Hear now this open letter in response to the sermonizing of Dr. Adams. Dear Mr. Former Surgeon General, racism is a public health issue that has made being Black in America a pre-existing condition. I encourage you in your influence as the former Surgeon General to push for racism to be listed as an option for coroners to check in the cause of death category after autopsies are performed on Black bodies. To your credit, you have made statements indicating your awareness as a Black man of the reality that being Black in America may be hazardous to your health. Mr. Surgeon General, you seemed to get it when reports began to circulate that COVID-19 was magnifying the systemic inequalities in this country and killing Black people at alarming rates. You told BET in an interview that the health issues that have made Black people so vulnerable to COVID-19 are systemic. You said, I quote, "We are addressing the social inequities that have occurred and that can cause poor health in our society." You even noted that social distancing is a near impossibility for many of our people because of the work they do and the neighborhoods they live in. You acknowledged to a predominantly Black audience as you were being interviewed by the BET channel that racism is an accessory to the killing of Black people by the deadly virus. Will you explain to me, therefore, why your message changed that day in the White House briefing room? You responded to a question from a Black journalist about the disproportionate impact of COVID-19 on our people in a flippant and condescending manner. Were you bothered that a Black reporter, a female reporter at that, would ask you about the deadly jolt of the virus on our people as you stood in the White House next to your boss? Dr. Adams, you seemingly adopted a persona of being the Surgeon General who happens to be Black, and you used your Blackness to both identify with and talk down to Black and brown people while appeasing your boss, who was probably your main audience. Your message of, we need you to step up and stop the spread, to a people who are already suffering the most, reflected poor bedside manner. Accordingly, your lack of diagnosis of systemic racism as the pandemic within the pandemic led you to prescribe self-help as a treatment plan. The victims of the systems that have allowed the virus to spread were blamed for their insufferable situation and told to take personal responsibility. Imagine, Mr. Surgeon General, how the family of Deborah Gatewood, a 63-year-old healthcare worker who lived and worked in Michigan, must have received your message. Gatewood, a Black woman, stepped up as a frontline essential worker in the war against COVID-19 in the tradition of Black women who have always put their lives on the line to heal our community as well as our country. She reported for duty every day at Beaumont Hospital. Eventually, Gatewood became infected while doing her job at the hospital where she worked for 31 years. When she fell ill, she took herself to the emergency room at that hospital. But guess what? Mr. Former Surgeon General, she was turned away. She requested a test for the virus, but she was sent home 4 times in less than 2 weeks. Her daughter, Kayla Carruthers, eventually took her mother to another hospital where she was finally tested for the coronavirus. By then, Gatewood had developed bilateral pneumonia and had to be intubated. Her kidneys failed and she died April 20th, 2020. Tragically, for Miss Gatewood, COVID-19 and the color of her skin proved to be a lethal combination because of the biases of healthcare workers who don't believe what Black people say is going on in their bodies. Shamefully, as you know, Miss Gatewood's experience was not isolated, but an illustration of medical apartheid, or the disparate discriminatory treatment that the coronavirus has exposed that Black people experience in this nation. What Ms. Gatewood experienced reflects the deeper sickness that has infected this nation from its inception, and it shows up way too often in the healthcare systems that maltreat Black people. In the last speech Martin Luther King Jr., the drum major of justice, ever gave, it was April 3rd, 1968, he dropped a line that we often overlook. In that speech, Dr. King said, "The nation is sick." And the sickness of America is reflected in the healthcare system as racism infects and influences the way Black people are treated. The doctor's office ain't a safe space for healing for Black patients who are suffering. In a series of studies published in 2017, researchers found an implicit preference for white patients, especially among white physicians. That poisonous perspective could have precluded Deborah Gatewood and so many like her from receiving treatment. A 2016 study of medical students and residents is alarming. Half of the potential doctors believe there are biological differences between Black and white bodies, including the invalid idea that the nerve endings of Black people are less sensitive than those of white people. This malady of the mind translated into the results of a more recent study that showed that Black patients were 40% less likely to receive medication to ease acute pain. That's sick and evil, Dr. Adams. You inherited and presided over a defective and diseased healthcare system that treats Black people as damaged and disposable. Instead of telling Black people to step up, you should have told the healthcare industry to step up and interrogate the racism that infects the way the medical profession cares for Black bodies. The healthcare system you presided over is indicted by the words of Dr. King, when Dr. King said, of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. Even though there is always a place for personal responsibility, we get that in healthcare. In your position as the nation's doctor, it would have been a transformative moment if you would have had the moral courage to diagnose the systemic virus that plagues our communities. You could have prescribed a systemic vaccine of wellness, wholeness, and justice for a sick nation that continues to infect Black communities. Mr. Surgeon General, you had the opportunity to remix the oft-repeated aphorism expressed in the Black community: when white America catches a cold, Black America gets pneumonia, by declaring when white America catches the novel coronavirus, Black Americans die. Or to remix Martin King, who said injustice anywhere is a threat to justice everywhere, I'll simply give it the Haynes translation and say infections anywhere are a threat to good health everywhere. Instead, Mr. Former Surgeon General, you chose to shift the blame to those victimized by this sick system and told us to step up. How do you step up in a deprived community that is forced to inhale toxins from landfills and incinerators that are the result of environmental racism? How do you step up in segregated communities that are healthcare deserts that suffer from food, job, recreation, and opportunity apartheid? Tell me, Mr. Surgeon General, how do you step up when zip code injustice has created residential segregation that causes one's life expectancy not to be determined by their genetic code, but by their zip code, says Dr. David Williams of Harvard. Mr. Former Surgeon General, how do essential workers step up when they are treated as expendable because Black lives don't matter in our nation's healthcare system? How do you step up when the above mentioned factors and others have resulted in life expectancy in America decreasing by a full year in 2020, but Black people lost 3 years of life expectancy in that same year? Mr. Former Surgeon General, it's time for the medical community to step up. It's time for this nation to step up and accurately diagnose how sick this nation is from the disease of racism and prescribe a treatment plan of justice, opportunity, and repairing and rehabilitating our suffering Black communities. I offer this treatment plan in the context of this conference of brilliant Black people who have come together to say, in this moment, it is our challenge to ensure that we create healthy communities. What do? I give you these and I'm through. Number one, Mr. Former Surgeon General, we must abolish medical apartheid in every form. I refer you to the brilliant work of the medical ethicist and journalist Harriet Washington in her groundbreaking study, Medical Apartheid. Medical apartheid, she says, reveals the hidden underbelly of scientific research and the ugliness of the history of stratified medical exploitation that African Americans have been subjected to, and the evidence that medical and scientific racism continue in the present. Her research provides for the first time an understanding of the roots of the African American health deficit. This cannot be corrected by avoiding drugs, alcohol, and tobacco. Mr. Former Surgeon General, the racial reckoning that this country supposedly has been going through since the murder of George Floyd and Breonna Taylor must account for the history of medical abuse and the systemic racism that vulnerable communities continue to suffer from. You will not have healthy people in a sick system that is presided over by the notion of medical apartheid. But then not only that, I want to submit that all human beings must be valued and treated with dignity. If this is to be a country of liberty and justice for all, if we as a nation are to quote Dr. King again, be true to what we said on paper, then Mr. Surgeon General, you who have proudly professed your faith in Jesus must recognize that we must create a country, a culture, a climate where all human beings are valued and treated with dignity. Mr. Surgeon General, as I said, you proudly profess your faith in Jesus Christ. I really ain't got time to ask which Jesus you're professing your faith in, because you do know there is a white Jesus and the right Jesus. And the right Jesus is the one who would allow your moral imagination to be ignited, knowing that Jesus, watch this, was on earth noted for being the great physician. Jesus of Nazareth, straight out of Nazareth, the hood, during his earthly ministry, the great physician ignited a revolution of valuing the disvalued. Ched Myers, brilliant New Testament scholar and activist, points out on his website that during the earthly ministry of Jesus, those who were chronically ill were considered disvalued. However, the Gospels relentlessly spotlight Jesus is healing those who were chronically sick. He valued those who were disvalued. We will never have a healthy healthcare system if we don't create a culture in healthcare that values those who are often treated as disposable. Dr. Adams, now is the time to create a culture in healthcare that values all humanity while repenting for and repairing past scientific and medical sins. Mr. Former Surgeon General, we must learn the wisdom of Professor Eddie Glaude Jr., who talks about the value gap in this country. We know about the wealth gap, but there is a value gap that basically says on the hierarchy of value, there are some lives that are valued more than others, and Black lives, sadly, are at the bottom of that particular pole of value. No wonder Isabel Wilkerson piggybacked on that principle in her phenomenal work that's entitled Caste, in which she says, if you want to understand what's happening in these disunited states of America, there is a caste system, C-A-S-T-E. This caste system, again, is a system of value where some lives are valued more than others. If we are going to reimagine what it means to push for, to insist on healthy communities, then we must understand that Black lives have to matter to this nation. But hold on, I'm talking to Black people. We must reevaluate what Black lives matter means to us. And that means we must understand that all of us are to be valued. And when we value each and every one of us as a cultural value, then we will set the stage. Here it is for my last piece, and that is creating healthy communities so that we can then have healthy individuals. Please don't get it twisted. We will never have healthy individuals as long as our communities are infected by the sickness that is America. We must insist on, here it is, ensuring that America is healthy in her disposition toward Black people. And once we do that, then we work hard to create healthy communities where we all have access to health care, healthy communities where we engage in the abolition of environmental racism, healthy communities where we all have access to healthy food, healthy communities where we all have access to recreational opportunities, healthy communities where we all have access to business and job creation and development. We must create healthy communities if we are to have healthy individuals. Y'all know I'm a preacher, so I got to go back to the Savior from the hood, our sable skin Savior from the streets, Jesus, the great physician, because he recognized it's hard for sick communities to produce whole people. In Matthew's gospel, Jesus made his healing ministry accessible to those who were on the margins and healed healed, the Bible says, all throughout the region of Galilee in chapter 4 and Gennesaret in chapter 14. I'm not in church, so I won't try to get y'all to shout, but if you get the context, you already know that both Galilee and Gennesaret, they were considered, here it is, otherized outpost in the occupation and oppression of the Roman Empire. But guess what happened? Jesus said, I'm going to create healthy communities in the areas that have suffered from occupation and oppression by the Roman Empire. And I'm simply trying to say it's essential that we fight for the creation for healthy communities that have access again to quality and free healthcare, because it's a right for all and not just a privilege for those who can afford it. Healthy communities again have access to healthy food choices. They breathe clean air and drink lead-free water. Healthy communities have affordable housing in neighborhoods with accessible services and again recreational opportunities. Dr. Adams, the United States desperately needs a vaccine from a virus that defiled it from birth. And I'm not just talking about COVID-19, I'm talking about COVID-16-19. May God give you and the medical community the moral vision and imagination to help us develop it, lest this virus becomes fatal, not just for our community, but for our nation. Yes, Mr. Former Surgeon General, it is necessary that we do this for the health of this nation, because a nation that is sick needs a virus, and this virus must contain a vision, a moral vision of what this nation can look like for each and every one of us, but especially those of us who have suffered because of the value gap in this nation. So, Dr. Adams, wherever you are, whatever you may be doing now, as the former Surgeon General, I send this letter to you in the hopes that you will use your influence and your inspiration to ensure that those of us on the bottom experience health, because when there is health from the bottom up, there indeed will be health and healing for all. Peace and power. Frederick Douglass Haynes III.
Wow, I couldn't even get to my mute button fast enough. If we could do this, Reverend Haynes, thank you. And it was the COVID-16-19 for me. That was the master touch on what you just said. If you could turn your cameras on, and let's give Reverend Haynes a chance to look at the gallery. We had church, you know the rules. If you were moved, just turn your camera on and wave your hand. Clap. Let's show some virtual love. I know it can be a little awkward when everybody can't turn their mic on because it would be chaotic, but just a wave of the hand. That was so good, sir. Thank you so much. Even a thank you can't do justice for what we just heard. But thank you.
Thank you.
Dr. Glover, people did not sign up to hear me. So let's bring you back. I know you want to put a ribbon on the day, and I'm sure there's a lot of thank yous that you would like to give out for today's session. So I will let you bring us on home.
I can barely speak. Reverend Haynes, thank you so much for your words of wisdom. I heard you a couple of years ago at a meeting, and I asked Siobhan when she was working on this conference with us, I said, is there any way possible that you could get him to close? And she delivered, and you delivered. And I see Siobhan now, she's in her car. Siobhan, I don't know if you can come off mute to bring greetings, but we see Siobhan and one of your other fans waving.
You see, Doc, here's Siobhan and Micah in the train headed to the vineyard, but we love you, Doc. Thank you so much. There's Dr. Haynes.
Love y'all, love y'all. Y'all didn't invite me to the vineyard, but I still love you.
Hey, Sharika, everybody. Appreciate you, Doc. And listen, Council on Black Health, more to come. Great job, everybody.
Thank you all so much. So our next step, so again, we shout out to our amazing amazing workshop committee. Shout out to Tiffany Eaton, Bryant, Tiffany Williams, and Adrian Cherry for running things in the background. You all did a fantastic job. Thank you to Tali Carr for being the MC. You were fantastic. Thank you to all of our speakers and our panelists. So I'm supposed to close with what's next. So what's next? You heard from Dr. Jones. She gave us a charge. She gave us a plan. She said that she wanted the council to be engaged in that plan, and we certainly take her up on that offer to be engaged with that. We invite you to join us on this journey. You see on your screen how you can join and become a member of the Council on Black Health. Reverend Haynes talked about a lot of things related to health in the Black community and moving forward. You heard about our Black Health Bill of Rights. A lot of the things that he talked about are encompassed in our Black Health Bill of Rights. You heard about bold actions that we plan on taking. We want to move toward achieving that Black Health Bill of Rights. We cannot do that by ourselves as an organization, nor would we try. And so we need all of you to be a part of what we're doing. And so please do join us, join the Council on Black Health. Last but not least, Tali mentioned at the beginning that we usually have a 2.5-day workshop. We did not want to keep you in front of your cameras for 2.5 days. And so we spread this out for 5 different sessions throughout the year. And today was our In This Moment session. And you heard our fireside chat was, we are no longer asking permission to save our own lives. We ask you to join us for our next sessions, because our next 3 sessions, appropriately named by our board chair, Renee Branch Kennedy, are going to be Don't Talk About It, Be About It. And so not only are we going to say we are no longer asking permission to save our lives, but we are now going to take the conversation further for our next 3 sessions, our learning collaborative, on bold actions with examples for research, bold actions and examples for policy, and bold actions and examples for practice. And so we are going to ask you to be a part of that learning collaborative and those conversations. So please, if you have not joined us, please join. Those of you who signed on today, you are on our mailing list and you will receive the information. If you have others in your community, we are open. This is not only research, this is anybody from the community. We all have the opportunity to be engaged in addressing the health in our community. And we encourage all of you to join us. If someone was not here who should have been here, please do encourage them to join us, to sign up, to make sure they get the information. I know we are over time, but again, thank you all so much for joining us. We look forward to seeing you in our quarterly sessions and hope to see you as a member for the council. Thanks so much. Have a great rest of your day.